Yeah. We're really happy to have him come down tonight. You know, we said, gosh, he's got to drive all the way from Seattle and, traffic from Seattle down here or vice versa is just horrible these days. I said, don't you want to do it by Skype or something from your office? We can do that. We've done it before. It works out fine. Nope, I want to be down there with you guys. I said, wow, that's pretty impressive. So we are really happy to have Dr. Robert Meier from Swedish Cancer Institute here tonight. Got trained down in California, I understand, and then came to the Great Northwest and has been here for some 35 years in radiation oncology. So radiation expert, Cyberknife super expert, and we're very happy to have you here tonight, and we got lots of questions.
Thank you. Thanks so much for having me. I came to the Pacific Northwest to join a friend of mine's practice because their practice was really the epicenter of prostate brachytherapy, seed implant, back 20-some years ago. And I indeed learned brachytherapy, and that was my go-to way of treating prostate cancer until about 15 years ago when we got a Cyberknife. So what I'd like to today talk about is how radiotherapy has evolved in the treatment of prostate cancer. And also how Cyberknife, SBRT, evolved from something called radiosurgery. I'd like to go over the results of a national study I did on using Cyberknife for treating early stage, newly diagnosed prostate cancer. And then also discuss how Cyberknife SBRT, the stereotactic precise treatment, can be used to treat prostate cancers that have recurred locally, or also it can be used to treat prostate cancer when it is metastasized. Well, to start with, talking about the evolution of prostate cancer, the linear accelerator that was first invented, some nearly 70 years ago, hasn't changed very much. This is a standard medical linear accelerator from the 50s. And it has the device on a gantry, and it rotates in a single, circle and treats in a single plane about a patient lying on a table, as you see here. So when we first treated prostate cancer 50 years ago, we used this standard linear accelerator. We would set up on marks on the skin, and we would treat with 4 fields. You can see that we have 4 beams coming in. The green area is the medium dose area, and the red area is the high area. There's the prostate, right there. But the prostate lies right next to the bladder and the rectum. Well, I mentioned that this isn't very accurate, so we had to treat. We spilled lots of dose at the bladder and the rectum. So standard external beam radiation for decades was protracted. We gave a little bit of radiation each day over many weeks, over 6 or 7 or eventually 8 or 9 weeks. And we had to stop at a dose that we hoped was enough to kill all the cancer in the prostate. Now this is for early stage prostate cancer that hasn't spread. Well, this treatment was used for a long time, but when we finally looked at our results, what did we find? The doses that I used to give 30 or 40 years ago, if we followed those patients that we treated with prostate cancer, brand new prostate cancer, first diagnosis, as many as 60% of them had their cancer come back. Well, we weren't giving enough radiation to kill all the cancer. So, pardon me. So what happened? Well, over the ensuing decades, we developed different techniques to try to give higher doses of radiation to the prostate. One method is called IMRT, intensity modulated radiation, where we use several beams hitting the prostate, but each of these beams we modulate in each pixel of each beam the dose, so that we can give a tighter dose around the prostate. Another type of radiation that was developed that could escalate the dose a little bit better was proton beam radiotherapy. It had two beams would come from each side, but these beams were, because they were protons, they could tune them so the beam stops only about 1 centimeter past the prostate. So using these methods, we were able to push this fractionated daily radiation dose up from what we used to give 30 years ago up to here. And what did we find? Well, 10 years later, our cancer failure rates got better. Instead of 60%, only 25% were fatal. Still not as good a number as we might hope for. I mentioned brachytherapy. The reason I came up here to Seattle, brachytherapy was invented about 35 years ago, modern brachytherapy at least, where we used an ultrasound in the rectum to be able to direct a needle that contained seeds, radioactive seeds that we distributed throughout the prostate. Brachytherapy allowed us to give yet higher doses of radiation to the prostate. It's done it's usually done under anesthesia, this procedure, but it requires expertise. You have to be good at it. Because once you drop those seeds in, they ain't moving. You got to get it in the right spot. Well, so brachytherapy gave higher doses, but was it really better for curing new prostate cancer? Well, there was finally, in medicine, to really know if a treatment is better than, one treatment is better than another, you have to do something called a randomized study. Because that eliminates selection biases and other problems. So finally, the Canadians did a randomized trial in high-risk prostate cancer, either intermediate or high-risk cancers. And they flipped a coin. Half the men had brachytherapy plus 5 weeks of external beam. And the other half had the standard radiation that I mentioned, just plain old dose-escalated external beam radiation. Well, these are the number of patients that had their cancer recur, 5 or 10 years later. And brachytherapy cut the recurrences in half. So it was more effective. Giving that higher dose of radiation to the prostate yielded better results. But what was the price you paid? Well, the incidence of urinary problems was 3 times higher in the brachytherapy arm. These are the rates of significant late urinary issues, bleeding from the urethra, scarring, or strictures, or those sorts of things. So why was that? Why did that happen? Well, because with brachytherapy, you can't control where every seed goes. In fact, you over-implant because you don't want to miss any part of the prostate. So you end up giving more radiation than you need to the urethra, for example, or the external sphincter that controls urine flow, that provides continence. So brachytherapy yielded better cancer control in newly diagnosed prostate cancer, but the price was triple the rate of urinary problems. Well, wouldn't it be nice if we could have a treatment that gave that same brachytherapy dose, but more accurately, where we could miss the urethra, we could avoid, or at least minimize dose of the urethra, miss the external sphincter that controls urine flow. If we could miss the bladder and miss the rectum, if we could give that same dosing, but with better accuracy. The challenge is with our external beam devices, like a standard linear accelerator, is the prostate, believe it or not, is a moving target. This is an MRI scan of a patient's prostate. Here is the bladder and the rectum. We're looking from the side. Here's the tailbone is here, the bowel's here. Here's the pubic bone, and there's the prostate. Now, unfortunately, I just tried this, and there's a glitch with the video, so it's not going to work, and I apologize. But if this video is working, you would see that over a 15-minute period, the prostate, because of peristalsis in the rectum and bladder filling, the prostate moves quite a bit. It can move by a centimeter in a minute. I'm sorry that the video, let me try it once more. But last time I tried it, it didn't work. No, it's not coming up. My apologies. But in any case, believe me, it moves. So when we treat prostate cancer, if we were to blow this part of the pelvis up, here's the prostate, there's the bladder and the rectum. We cannot, with standard radiation, we cannot just treat the prostate. We have to build a margin around it when we target it. And so, just like that picture I showed earlier, we treat a bigger area like that. And what does that mean? It means that we give full dose radiation to a portion of the bladder and a portion of the rectum. Mm-hmm. Well, so again, the way standard radiation has addressed this is we build a margin and then we fractionate. We spread the dose out over weeks, and we have to stop at a low enough dose. But what's interesting is when all this was going on, there was another method that was developed called stereotactic radiosurgery. It wasn't used for prostate cancer. It was used to treat spots in the brain, tumors in the brain, or arteriovenous malformations, or whatever spot needs to be ablated in the brain. And this radiosurgery was developed, and in parallel was a revolutionary way to treat tumors in the brain. This is the first gamma knife. It was developed 50 years ago by a Swedish neurosurgeon. And what is the gamma knife? Well, there's 200 cobalt-60 sources in a hemispherical array. And those cobalt sources are all designed to make a finely collimated beam that all intersect through one point. So you have any given beam doesn't give much radiation, but when you have 200 beams intersecting in a spot, you can ablate anything in the brain. Now, a little bit like the analogy might be when you were a kid, you probably played with a magnifying glass in the summertime. If you could get the light to focus on one tiny little point, you could light newsprint on fire. So Lars Laxell in Sweden developed the gamma knife, and lo and behold, when you use this device to treat tumors in the brain, for example, this is a woman with breast cancer that has metastasized here to the cerebellum. See that spot there? We treated that with a gamma knife. One dose, intense radiation. 2 months later, the tumor is shrinking. 2 years later, gone, hasn't returned. By contrast, with standard linear accelerator, with normal treatment, we would have treated a broad portion of the brain. The average control for treating breast cancer is 6 months. 6 months later, it's come back. This allowed us to completely ablate the tumor, kill every last cancer cell there. Well, the brain is a special organ because it is encased in a fixed skull. It doesn't move relative to the skull. So the gamma knife could be invented because you could screw this frame into the skull, and then that frame in turn was fixed to the gamma knife device. So you could be accurate to under a millimeter. Wow. With this device, right? With this machine. The problem is the rest of the body isn't encased in a skull. So, but this is John Adler. He's a neurosurgeon from Stanford. He spent early part of his training in Sweden with the gamma knife. And he thought, well, wouldn't it be nice if we could come up with the same concept, but for treating spots elsewhere in the body, outside of the skull. Well, how do you do it? He invented a device called the Cyberknife. And instead of having 200 cobalt sources in a fixed array, he put a linear accelerator, a lightweight linear accelerator, on a robotic arm. Same sort of robots that you use for an assembly line for cars. But instead of a camera, looking where to put the screw in or the rivet in, there were X-ray cameras on the ceiling, or X-ray sources on the ceiling, that would take X-rays, and there's a detector on the floor, and this device, rather than hold the patient still, would take a picture of the patient in 2 dimensions, from 2 different views, and if it saw any motion, correct for the motion. And then treat from one position, move to another position and treat, move to another position and treat. So you end up with 100 beams from a spherical geometry, all intersecting through the spot where the cancer is. In the case of prostate cancer, a new prostate cancer, this is a pelvis of a patient. The blue is the prostate. Each of these light blue lines is a beam that is focused through the prostate. We put some markers, gold markers, in the prostate. That's what the device sees. These X-ray units will look for those gold markers. And when the prostate moves by even a millimeter, it corrects for it and then treats. This is a Cyberknife treatment, the printout from one. The upper, this is the treatment, as the treatment went along here, for prostate cancer that is. These changes are the translational changes, corrections that were made by the Cyberknife, X, Y, and Z changes. The device also adjusts for pitch, yaw, and roll. So these are the degrees of change in the angular uncertainties or the angular changes that occur. Wow. So the physicists looked at this device for treating prostate cancer, the physicists at Stanford, and concluded that it can treat with under 1 millimeter of accuracy. Wow. So this type of treatment, this stereotactic radiotherapy, has different names because the treatment's evolved from different disciplines. But when we're treating a spot in the brain with a single dose, for example, gamma knife, we call it radiosurgery. But when we're treating spots outside of the brain, between 1 to 5 doses, we call that stereotactic body, to differentiate it from the brain, stereotactic body radiotherapy, SBRT. There's a new name for it that you'll see, and if you search the literature, medical literature, people are now calling it instead stereotactic ablative radiotherapy. Why do we use the term ablative? Because we're giving such high doses of focused radiation that we're ablating the cancer at the spot that we are treating. Well, I mentioned I came to Seattle to do brachytherapy, but about 15 years ago, we got a Cyberknife at school. And I realized that this was a way to do brachytherapy dosing, but with a machine more accurate than brachytherapy. Now, the first prostate patients treated with the Cyberknife were done at Stanford, where the device was invented. But we got our device, our Cyberknife, just a couple years later. So I wrote a multi-center study. And we included 21 Cyberknife centers throughout the United States. We started it about 11 or 12 years ago. And we had 21 centers enroll 309 patients with either low risk or intermediate risk prostate cancer. And we followed them now for, some of them now for more than 10 years. So how did I treat patients? Well, these are images of a prostate. This is looking from the side. Here's the pubic bone right here. There's that white thing. Here's the rectum here. This is the bladder here. This is the prostate, and this is the urethra running through the prostate. If we look at it from a slice like this, like slicing a loaf of bread. We call it an axial slice. Here's the bladder, here's the urethra, here's the rectum. So our treatment gave a high dose, a brachytherapy-like dose to the prostate. That's the hashed red here. But it was done in 5 fractions. Not with standard radiation, you do it over 8 or 9 weeks. We do it in just 5 fractions. We give it a big wallop each day. We give it 8 gray per fraction times 5 fractions. Well, because we're doing it in just a few doses, the actual radiation dose we're giving the patient is only 40 gray, but it's equivalent to 100 gray if you do it with conventional radiation, because we're giving it in 5 wallops. We also, at the same time, to a slightly larger area outside of the prostate, gave a stepped down dose to the seminal vesicles here, but also to a tiny margin outside the prostate. We gave a stepped down dose. Why? In case there's any microscopic spread that we didn't see on the scans outside of the prostate. We'll get that as well. This is all done in 5 doses. So we published this study a couple of years ago in the U.S. Radiation Journal. Our results, we did low and intermediate risk. Low risk, nowadays we don't treat very often. When we designed the study, we were still treating low risk. But in the intermediate risk patients, 5 years later, 97% were free from a relapse.
Wow.
How does that compare to external beam? This is the best external beam results you'll find anywhere. This was done at Memorial Sloan Kettering, where they pushed the dose all the way up to 86 gray. The cancer control rate was markedly better than the Memorial Sloan Kettering results. Do you remember that randomized study I showed you earlier, where they compared external beam to brachytherapy plus external beam? If we superimpose those results, that's the green line, it's identical to the Cyberknife. So, indeed, we appear to achieve the same results, which we would expect, because we're given a brachytherapy-like dose to cancer, we ought to see the same results. What about side effects? What about long-term side effects? These are the side effects we worry most about. When you treat anybody with radiation, they have immediate side effects, or temporary, they go away. We don't worry too much about those. We worry more about the late side effects, the ones that come on a year or 4 years later, because sometimes those side effects linger on and affect the patient's quality of life. So if you look at the late urine problems, the urine toxicity is the biggest issue with this high-dose radiation. If we look at late urine toxicity, here's my study. Here's some other Cyberknife studies. We gave a higher dose than they all did, and yet we still saw pretty low rates of toxicities. Now these numbers probably don't mean much to you. What's a grade 2 toxicity or grade 3 toxicity? Well, a grade 2 toxicity is a side effect that for example, required that you take a pill to fix. Like, let's say you had slow urine stream, you had to take Flomax. That would be a grade 2 toxicity. A grade 3 toxicity means you needed to have a procedure, like a urologist had to look inside, do a cystoscopy. A grade 4 toxicity meant that you had to have a major operation, like you had a colostomy or something. And a grade 5 toxicity meant that the treatment killed you. So, thankfully, we had none of those. But
You wouldn't collect too much money.
But if we compare, these are the Cyberknife series. This is my series, where we dose escalated, gave brachytherapy-like doses. But if we compare that, this is old-fashioned, inaccurate external beam. Here's IMRT results. Here's protons here, and this is brachytherapy. So we did at least as well as the best external beam patients. We did better than brachytherapy in terms of late urinary problems, which is kind of what we had predicted. What about rectal toxicities? Rectal or bowel toxicities? These are Cyberknife results. These are standard radiation or brachytherapy. We beat the pants off of them because we could stay off the rectum extremely easily because the device is so accurate. The urinary toxicity, you might ask, well, wait a second, why is it about the same as external beam? I thought it was more accurate. Well, yeah, we stayed off the bladder better, but we gave a higher dose, remember, to the prostate, which means the urethra, the prostatic urethra did get a higher dose. So we did about the same for long-term problems. We delivered a higher dose, got a better cure rate, but we did about the same urinary toxicity as IMRT, and we beat brachytherapy in terms of toxicity because we're more accurate. So for newly diagnosed prostate cancer, the Cyberknife SBRT has immediate side effects that are temporary and modest, that go away. Bowel complications are less than other forms of radiation. Urinary leakage is very uncommon. The other urinary complications, late urinary complications, are less than what you see with brachytherapy, and similar to external beam. And the cancer control rates are superior to IMRT and about the same as brachytherapy. And we are now publishing our 10-year data, same series, and the results appear to be holding to 10 years. So, I think I have more time. So that's the use of Cyberknife SBRT for treating newly diagnosed prostate cancer. But a lot of people here have already been treated with prostate cancer. What happens if the cancer comes back? Can you use the same device? Well, the answer is yes, and it can be used in a couple of applications. Stereotactic radiation can be used to retreat a cancer that comes back in the prostate, for example, after brachytherapy or after external beam radiation. And it also can be used for metastases. So why don't we talk a bit about that? To start, let's talk about a patient that had external beam radiation. This was in 2004 for a Gleason 7 prostate cancer. Well, 8 years later, his cancer came back, but it was an aggressive cancer, it's a Gleason 9 cancer.
Ooh.
So his PSA was moving up. So we retreated this patient with stereotactic radiation. Now, normally you would not retreat the same area with radiation, but the exception is you can retreat following external beam radiation with this very focused stereotactic treatment because it does a great job of staying off the bladder and the rectum and so forth. So it is safe to retreat people. Same is true in the brain. Like, for example, someone who had brain metastases with a gamma knife, if they were treated with external beam radiation to the whole brain, you can safely come back in and treat individual metastases with a gamma knife. So we treated this guy with 5 fractions. 3 years later, his PSA was undetectable. Last time we checked it, about a year and a half ago, it was still undetectable. Here's another patient that had a recurrence following brachytherapy, seed implant. Here are the distribution of seeds. He was treated in 2009. His PSA a year later fell from 9.6 to 1.9, and then started to move up. It was up to 10.8, and we did a scan, a PET scan. This was, I believe it was an ex-human. It could have been might have been a C11 acetate, I don't remember, but we did a PET scan, and sure enough, in the seminal vesicle, cancer came back. You notice there are no seeds there. Well, some cancer cells spread from the prostate to the seminal vesicle. That's why when I showed you, when we treat primary prostate cancer, we include the seminal vesicle in case there's any buggers that went up there. But anyway, with seed implants, this guy did not have external beam, he just had seeds. So cancer cell went right to there, and then a few years later, grew and lights up on the PET scan. So we treated this in 2015, 5 years ago. Here's our treatment. Here's the beams